My name is Elise Gordon. I'm a speech therapist. If you know me from Mondays, I teach 2 classes here on voice and projection for Parkinson's disease. But I also, as you can see, I work on the outside. This is like, again, my happy, fun place. Not that I don't like my patients on the outside, but I work for a company named Fox, but that's why big shirt. But anyway, I have to put like a little disclaimer in there. Today we're going to talk about dysphagia or swallowing disorders. I know on the flyers it said apraxia, and I had a little bit of a freak out at about 10:30 last night when I was finishing my presentation, because when I decided to, May is Better Speech and Hearing Month. So when I was asked to come and talk to you guys, I thought dysphagia would be a really good topic, because I think sometimes we think we have to have like massive swallowing issues to do something about it. But I wanted to educate everybody on what swallowing is and what problems we have, and how it can relate to Parkinson's or movement disorders. And then I saw that it said apraxia on there, and I had like this freak out. So I added a couple slides at the end about apraxia too. So you're going to get everything today, and I apologize if you're at home and this isn't for you. I will never know if you turn me off. But if you're here, you can pretend like you're going to the bathroom. Again, I will never know if you don't come back. But I think both topics are really hugely important. So just if you were here for apraxia, I apologize, but I will definitely address that at the end. And I'm going to talk for a bit, but then I really want to make it an interactive presentation. I want to answer questions, because that's why we're all here, right, as a resource to help everybody and have a good day. So thanks for coming. This is super exciting. We're going to talk about dysphagia. All right, so a couple things. I like to have a little agenda so you know what's going on. And then I forgot to put at the bottom, apraxia, because that was my freak out last night. But we're going to talk about what is dysphagia, signs and symptoms. What is aspiration that goes along with dysphagia. Sometimes you can have swallowing issues, but not necessarily have aspiration. So we're going to talk about the difference. Signs and symptoms of aspiration. We're going to talk about Parkinson's disease and dysphagia and how they go together sometimes, not all the time. And then the treatment and support of dysphagia, because once you learn what it is, let's talk about how we can make it a little bit better, right? And then, of course, we're going to talk about apraxia at the end, and then and it kind of all goes together. So, and then we're going to have a lot of time for questions. Okay? Sound good? Everybody on board? This is a hard time in the afternoon, right? Because we have a full belly, right? And so when I used to do some speaking out in like other previous positions, I was at a continuum of care campus, and I would do part of orientation, and I would beg them, please don't give me 1 o'clock, because everybody just ate lunch and they're going to fall asleep and they're going to be tired. But they always gave me 1 o'clock, because I was kind of a smart person, like a sarcastic person, and I'd get people laughing. So I got mad. I used to beg them, please don't give me 1 o'clock. But we'll be good. So this is a good time. So what is dysphagia? So dysphagia is a swallowing problem that causes a patient or a person to have difficulty manipulating food or liquid with their lips, their tongue, their cheeks, their jaw, or their muscles of their throat. And that's why, just on a side note, speech therapists are in charge of swallowing too. So you wonder, like, how do we get from speech to swallowing? That's the common link. It's the same musculature that you use to speak, you use to swallow. So about in the early 1990s, mid-1990s, it became part of our scope of practice to be a pioneer in swallowing and treatment of swallowing for people who have issues, not just people with Parkinson's, people who've had strokes, people have weakness, generalized discoordination. We see lots of people who have that. And the reason why dysphagia, or talking about swallowing issues, is so important is because it can cause aspiration, which is when food or liquids go into your lungs or foreign bodies. Saliva, medications, anything that you swallow or that's in your mouth can go into your lungs. And if you're not lucky, that can cause a pneumonia, which we don't need on top of everything else that we're dealing with every day, right? So dysphagia or swallowing issues can cause aspiration, that can cause with pneumonia. It can cause choking, dehydration, non-wanted weight loss, let's put it that way, right? Skin breakdown when you're dehydrated or you're thinner than you were. You can have skin breakdown or sores, pressure areas, which are hard to heal, and of course, pneumonia. So that's why we're hypersensitive, hyper-focused on it, and really want to draw attention to it so that we know what it is and we know how to fix it before it becomes a really big problem, right? So signs and symptoms of oral. So we're just talking about the mouth phase. The next phase is like the throat or the pharyngeal phase, but just the oral phase is so inability to control saliva or liquids in your mouth. So does anybody ever have, and you don't have to answer if you don't want to. If anybody's taking my class, they know you can always say pass, right? So just as long as you say it with your intentional voice, you can say pass. But does anybody have problems keeping liquids in their mouth? Sometimes they fall out. Yeah, right? Sometimes people say, why do you have so much saliva in there? And it's not that we have an excessive saliva, it's just that we have weak lips or tongues or cheek muscles that make it harder to keep the saliva where it needs to be in your mouth, right? So pocketing of food, if you ever have food kind of in between your teeth or in your cheeks or left over on your tongue or the back of your mouth, or the residue of food long after someone's been eating, or if you're swallowing a pill and the remnants of the pill are still in your tongue. And then also difficulties with mastication or chewing, right? So when we are a little bit healthier, a little bit younger, our body's more efficient, we tend to do something called spontaneous swallowing, which you don't even know about, like hundreds and thousands and millions of times, right? You're just spontaneously swallowing and you don't even think about it. But when you're a little bit weaker, or you have discoordination or poor sensation, sometimes the spontaneous swallow becomes a little bit less. And then what happens? You have saliva in your mouth that you have to almost remind yourself to swallow, right? So some more of pharyngeal dysphagia. Isn't that a cool picture of your lungs? I was pretty excited. I found that online. I thought that was pretty neat because we don't always get to see lungs. And at the top is your pharynx up there, your throat muscles, or what we know as the Adam's apple, and it goes all the way down. That's your trachea, where we don't want food and liquid. That's right. That sits right next to our esophagus. The esophagus is behind or in front, and then the trachea is behind, and then it goes right into your lungs. So signs and symptoms of issues in your the pharyngeal state or your throat stage of your swallow is coughing or choking or throat clearing before, during, or after a swallow, right? So you feel like, oh, it's going down the wrong way, right? That could be a sign. Sometimes we sound like wet and gurgly, because the liquid's just hanging out there right near our vocal folds, which sit on top of the larynx or the pharynx, which is like the beginning of where that goes down. So that can be a sign. Recurring pneumonia, like, man, I just can't stop I get this pneumonia all the time. And you don't really know why. That could be an issue. Sometimes having a change in respiration, so you might have more trouble breathing. Weight loss for no other reason can be identified. I think some of us wish we could just have a little bit of weight loss, so we don't know why, or we're not trying really hard, right? I don't know. But, anybody that's going through menopause, like my age bracket, we'd love to have a little bit of like unidentified weight loss, right? But I'm talking about, humor. We have to be humorous, right? Because if not, this can be kind of depressing and upsetting, right? So let's add a little humor. I'm sorry if that's offensive. I hope it's not. But, let's just have a powwow about swallowing, right? So complaints of swallowing difficulties. So some people really know, when I have that steak, I had a steak 3 weeks ago and it went down fine. And last night, man, we were out at dinner and I was just coughing and it wouldn't go down. Or with medications, or sometimes it feels pain, or you feel like it's there all the time, right? Has anybody ever taken a medication that kind of like scrape the back of their throat, and then you feel like it's, oh my God, it's still in there, and it may or may not be, but probably not, but you feel it. It's kind of like when you scratch your arm and you have this scratch, And I'm still feeling that scratch on my arm, even though I'm not scratching it right now. So that sensation can be there, but that's an indicator that maybe the swallow's not going as well as it used to, right? When someone makes a facial grimace when they're swallowing, that might indicate pain for someone who may not be able to express themselves as much. And then also impulsivity, like we just got to keep getting the food down. That could be an indication that we're having some issues. So we talked about signs and symptoms of that you're having trouble. So now I want to explain what aspiration is, because that's kind of like the next step in the continuum, right? So what aspiration really is entry of foreign material, food, liquids, vomit, secretions, acid reflux. You can reflux and then aspirate your reflux. You may not even be eating and you can aspirate. I know, big news, not fun, right? And it falls below the level of the vocal folds. I'm going to show a picture of the swallowing mechanism in a second, but the vocal folds sit on top and they close real tight and they move out of the way. Your Adam's apple, it moves up and out of the way so that the food and liquid can go down the esophagus. So that is a very big protection or reflex for us when we swallow, is those vocal folds slam together. There's a little muscle on top that's called your epiglottis. The vocal folds slam shut, the epiglottis slams down, and they move up and out of the way so the food and liquid can go into the right spot. So if you have trouble moving your legs, or if you have trouble coordinating your vocal folds to talk, you might have trouble coordinating them to move. Because swallowing is like a big muscle movement. It's something we don't think about, but it is a big muscle movement, and it moves out of the way. So you have to have all these things to happen in succession to have a successful swallow with no risk of aspiration. And then sometimes, especially in the Parkinson's community, people talk about something called silent aspiration. Has anybody heard of that term before? So a silent aspirator, or someone who's silently aspirating, is somebody who might have that issue going on and there's no coughing or there's no indication, hey, I'm having an issue, right? So in Parkinson's, it's a little bit more prevalent to have a silent aspirator. About 25% of people who have swallowing issues and also have Parkinson's disease diagnosis, they have what they call like a silently aspirating, because our sensation when we have Parkinson's is not great, right? So the coughing and the choking and the feeling that there's food there or liquid there, you may not have as good of a sensation there or a sensory system or input that it's there. So when you silently aspirate, so there's no overt signs and symptoms of aspiration or distress while you're eating or swallowing, but you might have difficulty breathing and not realize it, or you might have that weight loss or that pneumonia, and it's like, I don't know why I keep getting pneumonia. I'm swallowing just fine because we're silently aspirating. So not to scare you, but just something to think about, right? So here's our swallowing chart. So if you can see in number 1, that's the bolus of food is in the green, and it's going to come down. And then in 2, it's gonna, the soft palate or the back of the throat, you know, you have that little thing hanging back there called your uvula. If you come to my class, we work on that back of tongue exercise so very much, right? So that we can strengthen that coordination, because if you can get a good seal and push it down, there's less risk of aspirating or having trouble. So the 2, the food goes down the path all the way in the back of the mouth, and then 3, it goes all the way through to the esophagus. Number 3 in the back. So all your stuff is there, that epiglottis I was talking about, the vocal folds come together, and then the upper esophageal sphincter, it opens instead of closes. It's like opposite of everything else in our body. It opens, lets the food in, and then closes and keeps it really tightly shut there so nothing goes down the esophagus unless we want it to. Sometimes people have a dilation of their upper esophageal sphincter, say that a few times fast, right? The doctor will go in and they'll stretch it a little bit, because if it's really, really bound tight and then you move it to go swallow and it doesn't open as much, right, or doesn't open big enough, food can sit there And then you can have trouble because the food just stays there, and then you start breathing again. Because believe it or not, when you swallow for just a millisecond, you stop breathing. Like the body's supposed to do that. That's your reflex. So it closes off everything so nothing goes in your lungs, and it goes down the esophagus, and just for like a millisecond, you stop breathing. But when you start breathing again, which is a reflex, that food's still sitting there if that esophagus hasn't opened, right? Okay? So really important muscles, but you can get it dilated or stretched a little bit, and that does tend to help people. So if you have food or liquid kind of sitting there, and the way we know that is that we'll go to the ear, nose, and throat or the GI doctor, and they can put a very unpleasant but tolerable camera up your nose and down your throat, and they can see what's going on, right? Has anybody had that before? Yeah, you've gone to the ear, nose, and throat person, and they scope you, right? They spray a little numbing up there. It's not horrible. You don't have to do any prep for it. It's not as bad as like a colonoscopy or something, but it's still not very pleasant, right? So moving forward, so signs and symptoms of aspiration, right? There's coughing, choking, throat clearing, wet vocal quality, a change in vocal quality. You're clear, and then all of a sudden you eat and swallow and you're not. You know, sometimes people have watery eyes. If you just have watery eyes, I'm not going to be 100% concerned, but the whole package together, those are things we look for. Sometimes the speech therapist who evaluates the swallowing, we can come with a stethoscope, believe it or not, and we can listen to your swallow, or we can have the nurse who we work coincidentally with listen to your lungs, or maybe we'll say, hey, you know, I hear you swallowing. Maybe we're having an issue. Maybe we should go to the doctor and have your lungs checked out, and the doctor will listen, maybe take a chest x-ray. So we'll make sure that it's not, so like it says at the bottom, a chest x-ray, a CXR, positive infiltrates in your lower lobes. In our body, our lungs have, we have two sets of lungs. We have two sets of everything in the body, and most everything is symmetric, right? Even though, like the tongue, there's two halves of the tongue, even though you think it's just one tongue, there's two sides come together. In our lungs, one lung has 3 lobes and one lung has 2. So a lot of times when you have aspiration pneumonia, you'll have infiltrates in the right lower lobe, just the way the food and liquid goes down. So that's important for a speech therapist, not so much for a patient. But if someone says they have recurrent right lower lobe pneumonia, to me that's a big indication. And they might have a comorbidity or something going on like Parkinson's, or they just had a stroke, or they have weakness. That's a big like detective, like who done it, like, yep, they're having some aspiration issues and we need to address that. A runny nose too, it's one of the first signs, but if you have a runny nose and you're swallowing and you're fine and you don't have any of these other symptoms, don't run out and think you have aspiration pneumonia. You're probably okay. It's just like in the whole scheme of things, just something we look for. Obviously a fever if you're having pneumonia or you're sick. Sometimes people have a weak swallow or an absent swallow. So if you're having issues with swallowing and you go see the speech therapist, such as myself or someone else, we're gonna feel your swallow. We're gonna put hands on your neck and feel it. It doesn't hurt. We wanna feel the Adam's apple move and see if it's moving up and out of the way or anteriorly the way it should. And then also if I say, like, I'll just pick on Rick because he's right in front of me, but if I say, hey Rick, give me a dry swallow with all the saliva in your mouth. And he's pulling it together and he's thinking about it. And he's like, I'm swallowing, Elise, I'm swallowing. But it takes, like, I'm counting 1, 2, 3, 4, even though that doesn't seem like a long period of time, but in the swallow is fast. So I'm listening for that. So an absent swallow, or the next one's a delay in swallow, that's what that means. So he might take a sip of water and I know that it went down because it's not in his mouth anymore. And then the swallow takes 5, 6, 7, 8 seconds. That's a long time in the world of swallowing. For, 8 seconds is easy, if it takes 8 seconds for the elevator to open or 8 seconds for someone to pick up the phone, that's not a long time, right? But in the eyes of swallowing, that could be a symptom of aspiration, that it's going the wrong way or it's discoordinated. I picked cherries for this one because they have pits in them and they're really hard to eat when you're having swallowing issues, right? That's why I picked that one. So swallowing and Parkinson's disease. So swallowing problems for people with Parkinson's disease can be more severe as the disease progresses. Again, not everybody who has Parkinson's develops swallowing issues, but it is definitely something along with everything else that we have to look at, that we have to wonder about and always keep in the back of our mind just in case. Because if you can catch it early and change some habits, you can have really good quality of life and figure it out, right? We have a gentleman in class who's having some swallowing issues, and he went to a speech therapist and he had an x-ray of his swallow, and he learned that if he turns his head in one direction, all the food and liquid go exactly where it needs to be. And so he can, for the most part, have good quality of life. I mean, we love to eat, right? We're a society that loves to eat. Eating's very enjoyable, is very social, right? So he can still go out with his friends and be social. And he has a compensatory strategy that he can use to make sure that he's safer, which is why it's hugely important. I'll plug speech therapy, OT, PT all day long, right? Communicate with your physician or with your nurse practitioner or the PA when you have a change in your swallowing, because it's hugely important to get some compensatory strategies in there, because everybody wants to continue to eat and drink what they love, right? Like I love coffee, right? If you take my coffee away, I'm not going to be a very happy human, okay? You thicken my coffee, grounds for, some lashes with my stick, but you want to continue to be able to eat and drink what you like, right? And be social and go out with friends, right? So back to Parkinson's, but I just want you all to really understand and grasp the concept that just because you have Parkinson's disease or have been diagnosed that way, or Parkinsonianism, it doesn't mean that you're definitely going to have swallowing issues, or you're going to have swallowing issues now or later. It's just something you really need to think about, which is why it's hugely important to we're going to talk about it a lot. Maybe this summer will be the summer of swallow. I don't know. We're going to think about it a lot. So some of the symptoms, again, that mimic the other symptoms can be difficulty swallowing pills. We've talked about that in class a whole lot. When the pills don't come Tera-encoded, right, they're much harder to swallow because they kind of stick on your tongue, right? Yeah. And then what happens? We have to take pills like 4 times a day, right? So what happens? I'm going to pick on Joni because she's sitting right up here. What happens, Joni, if you're having trouble in the morning swallowing pills, and then 4 hours later you have to take another set? What's your mindset going to be around that? We need to drink more water. We need to figure this out, because it's not something that you can say like, today I'm having a problem with steak. I'm just not going to eat steak today. When you have difficulty with pills, we have to take pills, right? Because pills on time help us to have good function, right? So we might have some anxiety about taking pills, and then when you're trying to take pills and you have anxiety about it, that doesn't help out, does it? Not really. So hugely important to have conversations, right? There's tons of compensatory strategies, and most of us who are speech therapists who help people with swallowing especially, we don't stop until we figure it out. Like we're a big detective. Well, if that doesn't work, let's try this. And if this doesn't work, then let's try that. So there's always things we can try, okay? So again, coughing during meals, clearing your throat often or when you're eating or drinking. Some people only have trouble with liquids. The food is just fine, but the liquids are horrible. Some people, the food and liquid go down and then they just feel like it's stuck there forever. Some people take a really long time to eat and swallow, right? So sometimes when I go visit people who live in assisted living communities, and I say to like the nursing staff, like, hey, is anybody having any trouble, eating or swallowing or have dysphagia? They're like, no, Lisa, everybody's good. But then there's always the same lady who takes like 2.5 hours to eat lunch. And it was just like a half a sandwich and some chips, right? In my house, I have a 16-year-old and a husband. Boys, that would have been done in like 10 minutes, right? A little too fast for my liking. But, that's a huge indicator that it takes a longer amount of time to eat meals than normal. That can be an indication that you're discoordinated, and we can work on some strategies with that as well. And then just having a decreased sensation, not being able to feel when things are clear down there. So some more things about treatment and dysphagia and why it's important to talk about it and not keep it hidden or secret. So without proper treatment, swallowing problems can lead to malnutrition or significant weight loss, dehydration, aspiration and pneumonia, infections. And that if you're not feeling good and you have pneumonia, right, you're not going to be able to come to class on Mondays, and I would be sad, right? Or go play pickleball, or go sit outside and sweat, right? Like whatever you like to do, you're not going to be able to do that, right? So you have poor functioning. And what's one thing too that we always talk about? We really got to keep moving, right? Because if we don't move, if you don't use it, you lose it, right? So if you're not feeling well and you have pneumonia a lot and you're in bed sick a lot, you will have a decrease in functioning, and we don't want that, right? And also decreased socialization, right? We like to be social humans, right? And get out and talk to friends and meet neighbors. And, even in the summertime, it's really busy in Sarasota, right? Like people are staying, right? So, and then leads to weakness and decreased coordination, progression of disease and other comorbidities or other disease processes that you might have going on in your body. And then the worst part for me is to have an overall decreased quality of life, right? So, no one wants to face challenges or diagnoses or things like that, but there's always things we can do to increase quality of life. That's so important to me. Like, that's my number one important. Like, what do you want to do? What's your functional ask? Like, what's your why, right? So what's super important? So for me, if you ask me if I'm having swallowing issues, if the doctor or the speech therapist can ask me, I'm going to say, I want to drink my coffee. That's my why. Like, that makes me happy every day, right? So I know, silly, but that would decrease my quality of life if I couldn't have coffee. Like when I was pregnant with my son, that was a big bummer for 9 months, no coffee, right? No caffeine. Because in my mind, if there's no caffeine and it's not important. But so it's hugely important to know that, like, all the things we ask you as practitioners, if you have the right practitioner, it's always going to be, what's your function? What do you want to do? What are you struggling with that's important to you? Because what's important to you is not what's important to me, and vice versa, right? So we want to continue to have good quality of life, right? It's hugely important. So how are speech and swallowing issues evaluated? So a speech therapist will complete a detailed medical history. We'll ask a lot of questions, right? We ask tons of questions. We're like detectives, right? So we'll evaluate your lips and your face and your tongue and your jaw. We'll assess your speech and your voice and your swallowing. We'll feel your swallow, right? We'll ask you to describe any challenges or changes you have. And then sometimes we'll send you for an x-ray of your swallow, or where they do a FEES, where they do the endoscope, but they put a little dye in food and they watch the food go down. And then based on what all those things say, then we decide what areas to target and which strategies would work to help you prevent aspiration. So sometimes tucking your chin works when you're swallowing liquids. Sometimes doing a hard swallow works. Sometimes doing a post-swallow throat clear to clear anything that's up there works. Like my friend who's not here, Jeff, turning his head works. Sometimes just using liquids to wash food down, that works too. So on the x-ray, not only are they looking to see if any food's going into your lungs, but the speech therapist will then say, okay, turn your head to the right, based on what she or he sees on the video or the x-ray. And then they'll see immediately if that's something that will help. So you can get strategies figured out immediately when you do an x-ray of your swallow, which is kind of like our gold standard, because I can listen and feel for signs and symptoms, but I don't have x-ray vision, so I need help with the x-ray machine. So if it's important or we think there's a significant need for that, we'll recommend that. So difficulties noted with Parkinson's too. Sometimes the swallowing problems can be mild, like again, taking longer to finish a meal or having trouble swallowing pills. Sometimes it can be a little bit more serious, like the weight loss, the pneumonia. And then just like everything, unfortunately, with Parkinson's, it's things that we used to do before. And this is what my patients tell me all the time, and people in the community, is that the most frustrating part is the things that we used to do before without thinking about, now we have to think about them. So walking, swallowing, right? Like when you're a little bit younger, where you didn't have to really think about swallowing, we just ate. And you'd have that once in a blue moon, like where you choke on ice cream cone or something. But, you don't have to think about it every meal. And now it's something that we have to think about, spontaneously swallowing, which we didn't have to think about before. And then also decreased sensation, right? So just real quick, and then I'll open the floor for questions because I know I've been talking a lot. So what can you expect in a speech or swallowing therapy session, just so you're not afraid of it? We're very fun. We ask a lot of questions, just so you know. So it varies greatly from person to person. So a therapy plan, when you go there, should be individualized, like I said before, to your particular symptoms and also to your goals, like what's important to you. So I have a lot of patients who, when they see my physical therapy counterpart, what's the number one thing they ask? They want to go outside and walk their dog. So can you help me with my balance so I can go outside and walk my dog, right? So that's functional physical therapy, right? To have good balance, to be able to walk your dog. So my goal would be, of course, to have good swallowing so I can drink my coffee, right? Someone else's goal might be good swallowing so that when I go out with friends, I'm not drawing attention to myself, and we can go to a steakhouse and I'm okay, right? Something like that. So during speech therapists will provide exercises for clearer speech, muscle strengthening, communication strategies for you and your care partners, right? So we got to loop everybody in because this is like team effort, right? And then also strengthening the muscles of your voice in turn strengthens your swallowing because they all work together, right? And then it focuses on strengthening muscles used for breathing, coughing, and swallowing. So it's good, I always say if someone's coughing, like I don't want anybody to cough when they're eating and swallowing, but if you're coughing, then I know that you're still breathing, so we're good. When you stop breathing and stop coughing and you're totally silent, that's when I'll start running, right? So like I said, I have a son, and when he was younger, my husband's like, oh my God, he's coughing. I'm like, yep, if he's coughing, he's breathing, we're good. When you stop coughing and you stop breathing, then we have a problem, right? And they might sometimes have you use muscle strengthening for when you exhale. That's called an EMST, or we might recommend some diet changes or eating and drinking techniques, right? And then just real quick, things that you can do to start the process, even if you don't have swallowing issues. These are good things to do anyway. So lessen your distractions, right? Sometimes we eat while we're watching TV and we're not paying attention to what we're doing, right? Or stay focused on your eating and drinking. Don't talk with food, it should say in your mouth. I messed that up. Right, because if you're talking, then your airway opens and then the food can go down. So that's usually important to finish swallowing and then talk, right? And eat slowly, small pieces, chew it thoroughly. And don't try to eat, sometimes if you're having a really hard time, just small half teaspoons at a time. If it catches in your throat, gently clear your throat or swallow again before you take a breath. Do it over if you need to. Concentrate on swallowing frequency. So if you have a lot of saliva in your mouth, try and cue yourself to do some more spontaneous swallows. And some things that can help on the second part is like ice chips, lemon ice, lemon flavor water. Sometimes the acidity in lemon helps stimulate that swallow, but also cold helps stimulate a swallow too, which will help you swallow more often. Sometimes people just need something in their mouth. It can be a swallowing issue or a hazard to have like a hard candy in your mouth, but sometimes that little bit of taste or sweetness will remind you to swallow, so that might work for other people. Sometimes chewing gum, I've had patients of mine chew gum to help, have awareness of their swallowing and what's in their mouth. But don't chew gum unless it's recommended, because that is, an issue. And if you're chewing or is difficult or you're tired, right? If you eat so much and then you just can't do anymore and you're burning more calories, then maybe smaller meals throughout the day is a better idea for you, or have lots of snacks, high protein snacks. Sometimes thickening liquids can help, sometimes it doesn't. Sometimes just thickening liquids that have things in them, so drinking thin water is okay, but juices and iced teas and coffees and things we thicken just because we don't want to aspirate those. So it really kind of just depends on where you are. And then last but not least on medications, sometimes medications can be crushed, but what you need to do is you need to talk to the pharmacist and the doctor because some of the Cinnamate can't be crushed, like on extended release. Those can't be crushed because they are over time and you don't want them to be absorbed faster. So if you really feel like there's just one pill that you're just keeps getting stuck and you're having problems, talk to the doctor and say, is there a liquid form I can take? Can I crush this pill? What else do you suggest? Sometimes putting it in applesauce or in a thing of pudding helps it go down. Sometimes placing it all the way in the back of your mouth helps because that's the part, getting it from the tip of your tongue all the way back. Sometimes when it's not coated, it doesn't slide on back, right? But also sometimes if you have my grandmother used to take 17 vitamins at once and it used to make me crazy even back then because I was like, Graham, what are you doing? That's a lot at once. Sometimes it helps to spread them out, but I know we're on timed medication, so we got to make sure that the ones we spread out are the ones that are okay to spread out. But I've told the gentlemen primarily who come to class, because there aren't a lot of ladies, that it's really good to get a good pharmacist in your back pocket. There's a couple stores, I go to a CVS on Cattleman, the big Target near UTC, and there's the same two pharmacists there always. One works the opposite of the other's schedule. And it's just so nice sometimes to go into a pharmacy where they know you and they know your medications and they are a plethora. They have so many ideas too, right? So if you're struggling with all these medications and if you become hospitalized and then you come back and the doctor keeps changing meds and it's so overwhelming, if you get a good pharmacist to do a medication review and then you can ask them they'll know which pills can be crushed and which ones absolutely cannot be. So it's really good to have a good pharmacist in your back pocket. I feel like I'm just going to go off the beaten path here and say sometimes a good pharmacist is better than a good doctor. I'm just saying sometimes, because they know you really well. They can spend more time with you and they know your medications and what interacts with each other and what doesn't, right? So does anybody have any questions? These are the apraxia slides. We'll leave those for last. Questions that I can answer about swallowing? I just gave you a ton of information. Yes, ma'am. So I'm just going to repeat the question for the people at home. So asking about how we can start, doing some speech therapy for exercising, for strengthening, for swallowing. It does require, if you're going to use your insurance, it does require a doctor's order, just, speech therapy secondary to dysphagia, and they'll know what to write. And then you get it and we can put it through insurance. Any other? Yes. So the question is, should we be evaluated by an ENT periodically? That's a really good question. It's good to have a good relationship with an ENT also, because not only is it good to know what the vocal folds and the throat is doing from a Parkinson's standpoint, making sure that they're working in waves and they're strong to clear it. I mean, it's not to go haywire crazy, not to go if we're up to some of my patients, they'd go every 6 months. That's a lot, to go to the doctor a lot. But if it's good to have someone have a baseline established, it's good to have one in your pocket. Go for a baseline consultation. And then if you feel like you're having changes with your voice quality and you want to know how strong your vocal folds are, and you want a picture, but then if you're having swallowing issues or something is different, changes, then it's good to have a good ENT because they know what you were at baseline. So then you can establish, if there's changes. That's a good question. Nothing else? Quiet. Uh-huh. Sure. Uh-huh.
But one of the therapists, she gets Parkinson's herself, and she came up with, the sweatbands that you wear for playing tennis.
Uh-huh.
She just
Oh, yeah, wipes
she
it.
only have a pocket full of Kleenex. So if anyone
Yep.
has an issue with
That's a good suggestion. So I'm just going to tell them at home that they went to a Parkinson's symposium in Port Charlotte, And one of the therapists who actually has Parkinson's herself has sweatbands, and they just use it as kind of like a, instead of a Kleenex or a, we used to call them dude rags, you know, the bandanas or whatever around your neck, showing my age. But yeah, yes. And then also oral motor exercises, chewing gum, sometimes candy, whatever, just to stimulate the swallow helps a lot. Cold ice pops, because it's hot all of a sudden, it's really hot. It went from like relatively cool to now it's really hot. So there's nothing wrong with a good old ice pop a couple times a day. Keeps you hydrated, makes you feel good, makes the throat feel good, and stimulates the swallow and strengthens your mouth. Anybody else? If anybody at home has a question, then you don't want to use the chat, you can use the chat. I can read the chat. Just so you know. Okay. All right, I'm just going to talk about apraxia really quickly, and we can answer questions about that just because I feel badly because that was what was on the schedule. So apraxia is a little bit different. It kind of goes with all the things that speech therapists look at, but it's the inability to execute purposeful, previously learned motor tasks despite physical ability and willingness as a result of some issue with your brain. So for example, you can have like limb apraxia on one of your legs where the leg works just fine when you are walking, but when someone asks you to volitionally or voluntarily move that leg or that muscle or that joint, you just can't. There's like a blockage to like the response. Or like, for example, you can have oral apraxia where like you can move those muscles and they're strong when you're eating and swallowing and you're just doing your normal things. But if a speech therapist comes into the room and says, you know, say, ooh, they can't do that, right? Or sometimes you can have, you know, verbal apraxia where you can't say words, but then if the phone rings and it's a normal volitional, you know, kind of like call that like a sequence or, you know, a schematic thing, you can pick up the phone and start talking. But if I say, Joni, hi, how are you? Say hello. She just blocks it out. That's being apraxia. And there's no specific treatment for it, but physical occupational therapy for legs and things can help to retrain, you know, it's like that muscle memory. So it just kind of depends on why we think it's happening. But it's weird. Like I've had people who have like apraxia in their vocal folds. So like we've gone to the ENT, we've gone places and there's nothing wrong there. They're strong and straying and moving because, you know, when you have trouble turning on your voice box, the first thing I want to know is if one of the vocal folds is paralyzed and they can't make good contact. But she didn't. She just had trouble turning it on and she had had a stroke, like a different set of challenges. And she just had trouble. She was apraxic in her voice. So like she could, if someone called her and she was a professionally trained singer, so she could sing, right? But if you want to have her turn on her voice box to communicate, she had trouble. So it's very interesting, very frustrating, extremely frustrating. But just try to make this a little bigger. So just, you know, signs and symptoms, you can have it in your cheeks or your lips. You can think about it, you can have it in your limbs and sometimes moving your eyes. We're not really sure what causes it. There's just something wrong with the brain. So you can have it from a stroke. It can happen with dementia, Alzheimer's disease, or with Parkinson's. It can. It's not quite as prevalent as, you know, say like issues speaking or what have you, or traumatic brain injury and accident. So it's really hard to diagnose because everybody is totally different. So there's not just like a normal flow. It's just something in the back of your mind. I've seen it more with people who have had a stroke, for sure, or a traumatic brain injury. And then speech and occupational and physical therapy. We have lots of good ideas. And as therapists, we never stop. So we just want to help. So if that doesn't work, we try again. And if that doesn't work, we try something else, right? Any other questions? Yes. Uh-huh. Yes. Uh-huh.
with their
Yes.
help, but it's definitely the brain.
Yes. So the question was with autism, they can be apraxic as well. Yeah, we see that in children too. And that's frustrating too because you don't know why or where it comes from, or it's very hard. It's harder to fix, right? If you don't know the why behind it, it's harder to fix. And some days, it's just inconsistent too. That's what's frustrating as well. It's just very inconsistent. But just stay hydrated. That's another thing too, that people, like if you're having trouble eating and swallowing, they just stop eating and swallowing, and that is not a good idea, right? All kidding aside, we need to continue to eat and swallow. And if it's like very exhausting and you just can't make it through 3 big meals, then let's do 6 small meals, or let's have a yogurt in between, or let's come up with a plan, like have a protein shake or something. We'll figure it out. But there's always things we can try. So don't be afraid. Just bring it up because, as practitioners, we don't know, and loved ones, they don't know. So you have to, with everything else, I know, communicate, right? Yes?
For Mike, sometimes I think we should do 4 meals, but it depends on salmon. No matter what size he gets, he finishes it all.
Okay. All right.
The easier it is to swallow,
Yep.
the better.
Yep.
He eats, otherwise he can't. No, I'm done.
Yep.
Just eating a portion of it.
Yep. So some foods are easier to chew and swallow. Gravy is our friend, right? Make it nice and wet and sloppy, and it's a good meal, right? Think meatballs and meatloaf versus hard to chew steak. Meatballs and meatloaf all day long because they have gravy, right? And if they're made right, they're not dry, right? A good meatloaf is not dry. I've learned that. I've been married 20 years. Bless my husband. He'll eat anything I make. And his most favorite meal, it's weird to me, is meatloaf. I never ate that as a child. I never knew how to cook it. But man, if you make that dry, you'll hear about it. But if you do it correct, I've perfected my recipe. You can make that nice and moist, put a little barbecue sauce on it, and you're good to go. A hamburger is much easier, Salisbury steak, much easier to eat than a real steak. And you can always get that out, right? So there's always choices, good choices. But salmon, I'd make salmon every night if that's your favorite, right? There you go. And then you can mix it with things like mashed potatoes, like a shepherd's pie, things that are mushed together that are still like appetizing to eat. Like I'm not saying puree everything, but like I'm a big proponent of like cottage cheese and yogurt and fruit together if we're having trouble swallowing bread or something for breakfast. But make it appetizing, make it look normal, make it taste normal. You can use a food processor, make some really fine pasty tuna fish that looks and tastes like tuna fish, but so much easier to get down because there's not pieces in there. Same, you can blend cottage cheese, you can blend all the things. Like there's so many things you can do. You just gotta figure it out. Like I said, we're detectives more than anything. Anything else? Wow, you guys make it easy for me. Thanks for coming. See you around.